Good morning.
Good morning.
Hello.
That's better. Okay, welcome to the fourth and last Breakfast with the Expert seminar for this spring semester. I'm very pleased to welcome to campus today Dr. Chris Neglia. Dr. Neglia is a hospitalist, physician, and a member of the board of Halston Medical Group. He is a board-certified physician who is very well known in the Kingsport community for his care and compassion. It is this interest in the well-being of his patients, combined with his leadership skills and his innovative thinking, that drove him to establish with his colleagues the Extensivist Clinic of Halston Medical Group. The Extensivist Clinic is a novel model of care delivery for high acuity patients, a model that promises to improve the quality of care and the health outcomes for those acutely ill patients while reducing the costs of care. We're very fortunate, that Dr. Neglia is here this morning to share with us his experience in establishing the Extensivist Clinic, the lessons that they have learned, thus far, the experiences of the patients to date, some opportunities for students to get involved, with the clinic in terms of evaluation, data collection, quality improvement, and perhaps most importantly, what all of those changes in healthcare mean for the training and the future of public health graduates. So thank you so much, Chris, for being with us this morning.
Well,
and
thank you for having me.
We look forward to hearing from you.
Thank you very much. Thank you all for having me. I am a grad of ETSU, the Family Practice Residency Program. I did it up in Kingsport with Dr. Blackwelder, and I've been out practicing as a hospitalist. And if you don't know what a hospitalist is, that is pretty much a generalist who only works in the hospital. I don't have an office. I take care of our group and several other local groups' patients when they go into the hospital. The ER doc determines if they need to be admitted or not. I go down to the hospitalist goes down to the ER, admits the patient, follows them through the course of the hospitalization, and sends them back home. And so that's what a hospitalist is. Bear with the first 10 slides. It's kind of a setup for the Extensivist Clinic, how we got there and how we came upon all that. I did want to just real quickly tell you the group. I work with Halston Medical Group. I guess I've been there about 10 or 11 years. We're independent, multi-specialty, physician-owned group and physician-led group. Our president's Dr. Fowler. He's an OBGYN and a lawyer, but now he's our president. Qualiable is the accountable care organization that we're in, or we're in this with SOFA, who's down here in Johnson City, and several other primary care groups. We also have this HIE, Health Information Exchange. This is the only one in the community, and this can link different electronic health records. So if one hospital has Allscripts and one primary care provider's office has Epic or whatever, this HIE that we have allows an interchange of all of that information, and that's open to anyone who wants to come into that. Obviously, a lot of what I do, a lot of medicine is information, just exchanging. If you have a test done in an office, and these tests aren't cheap, just a simple blood test can be $200, and then the patient goes to a different care venue, the hospital, and you've just had this same test done an hour ago. If you don't know that it was done already, you're going to repeat it, a $200 test. So this is our group. This is just a bubble map of where we are. It's 26 running through here. And this is the accountable care organization based by population of the different people. So this is the area that we cover with our group. But I'll move on to the topic. So this is the mission. This is kind of self-evident. This came from Dan Cortez. He's at University of Arizona State Public Health. Changing the way care is provided to patients who are the sickest and require the costliest treatment offers the greatest opportunity for improving the population health and for reducing the cost of health care. So what does this mean? You guys probably already know some of these stats. You hear out there, 5% of our country's population consume about 50% of healthcare dollars. 50%, the lower 50% of healthcare consumers only consume 3% of the healthcare dollars. So you got this little, 5% that are going through half of all our healthcare dollars. That's the sickest. That's who we're looking at, and by affecting the care we do to them, we can obviously affect things and get the biggest save for your money with that. Getting to our extensive model and shaping this is just something interesting. Biggest sources of spending, so think of your 5% of people in this country who are spending half of all the healthcare dollars. Where are they spending these dollars? In acute care. Highlighted acute care, I'll use that term acute a lot. When I say acute, that only means hospitalization. They're sick enough that they have to be acutely admitted to a hospital or an ER. But these 5% of the healthcare big spenders, the really sick people, where are they spending their money? 55% of those healthcare dollars are spent in emergency department visits and hospitalizations. So big cost right here, and this is where we're hoping to affect some change. And how big, how expensive are these things, ERs and hospitalizations? Just give you a couple examples, so let it hit home. There's an ER nurse at the hospital I work at. She works in the ER. She's young, about 30, came in with palpitations, her heart was racing. She was given this medication called metoprolol that costs $2 an injection. She had the ER doc's ear, rubbed her carotid artery. The medicine slowed her heart rate after 3 doses of it. She works at this ER. She was there maybe 3 or 4 hours. $4,500. That's what an ER costs. It's crazy. I spent a year in Costa Rica for less than $4,500. This was 3 hours. Hospitalizations in general, $15,000 to $20,000. That's just your starting point for a 3 or 4 day hospitalization. That's a car. So you go to a hospital a couple times, big dollars there. And so that's what we're looking to change a little bit. And this is, we cost a whole lot of money in a hospital, but are we doing a good job there? And I'm going to say no, and I can because I work in a hospital. Does anybody watch Seinfeld at all? Do you remember the Seinfeld episode with the dentist Watley who became Jewish, and Jerry thought he became Jewish only so he could tell Jewish jokes? Well, this is the same thing. I became a hospitalist so I can put down hospitals here. But this is something, for me it was a seminal article. There's no science behind it, but this guy Krumholtz, he's a cardiologist. It came out in New England Journal in January of 2013. And when we read this, it hit home. It is right on the money, and we see it firsthand. Again, we have no science to back this up per se. This is just his theory, but he came out, he coined this term, and it's flying around everywhere, PostHospital Syndrome. And he says it's an acquired transient period of vulnerability that might derive as much from the allostatic, I don't even know what allostatic means, and physiologic stress that patients experience in the hospital as they do from the lingering effects of the original acute illness. So what does all that mean? That means doesn't matter what's putting you in the hospital. You're going to the hospital because you've got pneumonia, you're going to the hospital because you have a heart attack. Take out why you're in the hospital. Just the mere fact that you are going to a hospital, you're going to come out vulnerable. You're going to come out behind the gun. You're going to come out less healthy, less better than when you went in. And what is how did he get to this, and why do I believe in it so much, and why is the physician community talking so much about this? Well, these are things that he outlined, and you see it, and if you have a loved one who's been in a hospital recently, you've probably seen it. If you've been in a hospital recently, you've probably experienced these. But sleep deprivation, I'll take you through a hospital admission. You go to the ER around noon on one day with pneumonia. ER doc will get to you in about an hour or two, so then it's 2 o'clock. He says, oh yeah, you're sick enough, you need to come into the hospital. I'll call the hospitalist down to admit you. Hospitalist comes down 3 or 4. They talk to you, write orders. It's about 5 or 6 o'clock in the evening. Patient stays in the ER because there's a bed hold, which happens all the time. I mean, you've got people lined up in the hallways and they can't get them up to the floors. You're stuck, and I see this every time we do it. You're stuck in the ER till about 10 or 11 o'clock at night. ERs are very noisy places. You're not going to get much rest. You're sick on top of that. Right as you're falling asleep at 11 o'clock, they move you up to the floor. New nurses, the nurse is going to wake you up, take your vitals, talk to you, ask questions, put you to bed. Right as you're going to bed, 1 o'clock, somebody is going to come in and draw some labs on you or come in and do something or other. Just crazy stuff that you never even think would happen, but it happens. You don't get any sleep. Right around 3 o'clock as you're falling off to sleep, they're coming in to get your morning labs and morning vitals. So sleep deprivation happens in the hospital all the time. Plus, you're not even in your own bed. Hospital beds are uncomfortable. You're scared because you're sick and there's a lot of things going on. And hospitals are noisy places to boot. So you have that going on. Nutritional deficits. I hold people NPO, that means without food, a lot of times because we have to do tests where they have to be on an empty stomach. So you're not letting them eat half the time in the hospital when they want to. When I do feed you, it's going to be food that you're not used to. It's going to be a special cardiac diet. You're not going to eat much of it because it's going to taste bland. It's not the food. So people come out nutritionally behind the gun. Deconditioning, and this is the biggest one. You go into a hospital, and here's a little something somebody could study. How much time are you in the bed? I would guess 95% of your hospital stay, you are in bed, lying down in a bed. Can that be good? You're in there for 3 days. Take an elite athlete who's 18 and put them in bed for 3 days in a row and let them only get up to go to the bathroom, which is right next door, for 2 minutes, and then that's it. You're going to get weak. The astronauts who go in space, they are very well conditioned before they go up. No gravity, they're not using any muscles. They come back down just after a week and they can barely walk around on this planet because just in that time their muscles have atrophied. Do that to an 80-year-old and what happens? Cognitive overload. This is more for elderly patients, but it's for everybody. We tell you you've got aspiration, pneumonitis, all these big words coming at you. You may only have a 6th grade education, as a lot of the patients do. You've got different doctors. You've got your doctor, your home doctor, primary care doctor for 20 years. Is he there anymore? No, you get me. They don't know me through Adam. Then a different doc, they saw the ER doc. Then I'm the night guy, so there's going to be another doc coming in the morning. There's different nurses changing shifts, and they don't always give them the same patient the next day. So you're throwing all these different things at people. At a time they're already sick, they just get very confused. Then we give medications. We give sleeping pills to help you sleep even though we're keeping you up. And give a sleeping pill, I don't know if any of you have done Ambien or something, give that to an 80-year-old and see what happens. They start hallucinating and having bad problems. So this is something I really believe is real, and this is why hospitals, for a lot of patients, there's a lot of issues going on. And we wanted to, this is kind of something that pushed this whole model of an extensivist clinic, which we'll get to in a little bit. This is actually before that article came out. This is 2009, but it was actually done 2007 to 2009 in New England Journal. Hospital, we do we've got this thing called PostHospital Syndrome. Well, here maybe is some of the science behind it. 30-day readmissions. CHF stands for congestive heart failure, very common diagnosis. Heart doesn't pump well, lungs fill up with fluid, you can't breathe, you get admitted to the hospital. From 2007 to 2009 with Medicare patients, 25%, 1 in 4 of these patients admitted to a hospital during this period of time had to get readmitted within 30 days. Most of them, the median came back in about 12 days. I'm not surprised. MI, that's a heart attack. 1 in 5, 20%. Back to the hospital within 30 days. We do a crappy job. I do a crappy job in the hospital. I mean, we need to do better. Pneumonia, almost 1 in 5 coming back. Interesting, this is just a little sidebar, but the reasons these patients are coming back, not always the same reason. They're not coming back for the pneumonia. The congestive heart failure, we squeeze the fluid out of them, and then we end up putting them into kidney failure from pulling all the fluid out. So they may come back for different reasons. They may come back because of post-hospital syndrome, where they just were weakened and deconditioned and sleep deprived from being in that hospital that long. So that just kind of supports this post-hospital syndrome a little bit. What else is, and then go back to the slides from the beginning. Where's all that spend? ERs and hospitals. Well, after a patient's been sent home from the hospital, they're not only getting readmitted within 30 days, 40% of them go back to an ER for their follow-up. The ER doc doesn't know them through Adam. Yeah. You just get sent home from a hospital, you should go back to your doc who's known you for 30 years. But 40% were within 30 days. Their first visit back was in an ER with an ER doc who probably doesn't have their electronic health record, doesn't know them through Adam, and probably doesn't know what happened in the hospital. Is that the right person? Is that the right place for that patient to be? And obviously it causes fragmentation in care. You've got too many cooks and nobody knows what's going on. Duplication of tests like we talked about. They're ordering things that may have just been ordered. And so we're seeing that too. And so this is just my personal feeling. We have a healthcare environment right now that leads to the hospital. Everything is directing people to the hospital. And here are some, these are just my thoughts, no science behind it, but why is this happening? Well, we're not doing a good job in the hospital, number one. Patients are getting readmitted. But we're in a hospital-centric healthcare environment. What does that mean? Well, it means hospitals are running the show. They are buying up doctors. They are employing physicians right now. They're buying up primary care practices. They're buying up cardiologists. The physicians, the docs, those are the gatekeepers into a hospital. So if I'm employed by a hospital, my boss is going to want me to, where's the big money? Where's the big spend? In the hospital. My employee, what does he want from me? Put him in the hospital. So we have that going around. You see people advertising for ER stays. We advertise to come to our hospital. It's all pushing patients into a hospital where there's a big spend. Also, what is leading patients to the hospital? And again, this is just my thought, and I can say this because I am a hospitalist, but I blame our hospitalist movement. I blame hospitalist doctors for putting patients in the hospital. I mean, the hospitalist movement came about 15, 20 years ago, where office docs didn't have the time to go back and forth to the hospital to see patients. They'd have an office full of patients, and if their patient in the hospital started getting very sick or crashing, it's tough to leave an office of 20 patients, run over to the hospital and address somebody coding or something. So the hospitalists came by to allow docs to stay in their office and then docs to just focus in on very acutely ill patients. And it sounded like a good idea at first, and it has its merits, but what is a hospitalist? Cardiologist, what does a cardiologist study? The heart. What does a hospital study? What's his thing? Admissions. That's what I do. I admit patients. Cardiologist, heart. Hospitalist admits patients. So, forgive the cliche, if every patient is a nail, my hammer is admitting. Hospitalist. That's all I do. Admit, take care of them. And so we've got this whole, and it's one of the fastest growing subspecialties in medicine now is hospital medicine, and the whole goal is to put people in the hospital, take care of hospitalized patients. And so we've created this mentality that all these docs know is doing that. Also, it's created this schism too. The primary care docs who once would come to the hospital, they've gotten out of touch with managing acutely ill patients in the hospital. The medicines diverge. They're very good at preventative care in their office and office-type clinic-based medicine, but they may not have been in a hospital since their residency 15 years ago. And when a patient gets very sick, I don't know what to do. Send them to the hospital. In the previous days, they would manage these more acute illnesses, but now they've lost the confidence to do it. They've lost the repetitive nature of doing it, so they're not comfortable admitting patients anymore. And they're not comfortable taking care of acutely sick patients because they just don't do it. So, we may have caused this road to the hospital. Also, in our healthcare environment, there's really only two options. If you're really sick, what are your options? You can go to your doctor of 20 years who probably knows you pretty well, but he's got maybe an hour to spend with you, and that's even pushing it. What's your other option? The hospital. There's a lot of pay, and then you're admitted, and $20,000 later. There's no in between, and a lot of people, in my experience, you give them 4, 6, 8 hours of some kind of intervention, some kind of support, you can stabilize them enough that they could potentially forego a hospitalization. But we don't have that. We have an hour in the office, tops, and you rarely get that. And if the doc, that primary care provider, thinks you are going to take more than an hour of his time, you're too complicated for me. What's my default? Hospital. Also, with our current fee-for-service model, and what does fee-for-service mean? It means I see you, I get paid something for seeing you. That pushes people to the hospital. One sick patient that may take 2 or 3 hours of time in the office, I could see 8, and with the office code, you could probably, the highest level office code, say $240 to see a patient in the office for 2 or 3 hours. Well, in that same time, while I'm trying to tend to that patient for 2 or 3 hours, I could see 8 patients, less complicated, at $100 a patient. That's $800 versus $240. What are you going to do? You're going to see 8 patients, say, you're too sick, go to the hospital. Same thing with the hospitals. They're still under this fee-for-service model. You get admitted for your congestive heart failure, they get a fee. They get, $15,000 for a diagnosis of congestive heart failure. Guess what? If you go home and you come back with heart failure again, they don't care. They're going to get patients readmitted. They're going to get another $15,000, $20,000. So the government has started instituting, if patients are coming back within 30 days, they ding the hospital a little bit. They say, we're going to not pay you as much because your patients are coming right back. It's only, I think, 1% now, and it's going to go up incrementally, these fees to hospitals for having their patients readmitted within 30 days. But you know what? Hospitals don't care right now. I mean, so what if they're dinged 1% of all their payments? You just readmit somebody, $20,000, I get 1% taken off of that, it's $19,000, but I got $20,000 for the first hospitalization, they're back in 2 weeks, I'm getting $19,000. So this current model we have fosters hospitalization. So that kind of, I think gets us to, and this is, I don't know if any of you have read this with your studies. It's worth reading if you haven't. This Dr. Macri, he's a gastroenterologist from Johns Hopkins, and he put this book out back a couple of years ago, Unaccountable. It was a New York Times bestseller, really worth reading. And this is a quote, I know I've been given a lot of quotes, but it really hit home for me too. A hospital is no longer the community pillar I knew growing up, with its altruistic mission guiding its decisions. When I was a kid, hospitals weren't there to make money. Their goal was to take care of the community. There was no advertising for a hospital. You didn't want to go to the hospital. It was there if you needed it. It used to be run by churches, because you took care of the poor and the needy. But now it's big business, these hospitals. And so, they have these hospitals, they're merging, they're transforming into these giant corporations with little accountability. What the whole book is mostly about is the lack of transparency with hospital charges. You can get charged $5 for a single Tylenol. You don't even, and it could be different at a different hospital. So we're not capturing these charges. They just make things up as they go, and you can't even track it and figure it out. But the bottom line is, hospitals aren't what we used to know them as. These places for the poor who have no money and are not there to make money. They're there to take care of the needy. It's become business, and so that, take it for what it's worth. But I would recommend reading that book. So what is an extensivist clinic? There's a couple other extensivist clinics, or several of them across the country right now, and there's different models of it. But the whole idea is extending out of the hospital, taking care of that 5%, those really sick patients outside the hospital. Some of them out there are clinics for recently discharged hospital patients, or they call it a post-discharge clinic, meaning these patients are leaving the hospital, they go to this clinic first because they're coming out with that post-hospital syndrome. They're coming out likely to be readmitted. They send them to an extensivist clinic to kind of stabilize the patient back into society. They may take more than an hour to see. The primary care doc may not have the time to devote to these sicker patients. So that's one form of an extensivist clinic out there. There's also disease-specific clinics that they're calling extensivist clinic, meaning you have all you see is heart failure patients. You have this special clinic. Everybody who's got heart failure comes to you on a stable condition. You follow them very closely. They're that 5% that are in and out of the hospital, and you try to manage them very closely by keeping on top of them, seeing them every 2 weeks, calling them at home. Are you not drinking too much? You're watching your salt. So that's an extensivist clinic. And then there's also extensivist clinics for, every group has taken we know who our 5% is. Our group knows our big spenders. We see who goes to the hospital all the time. And you send those to these extensivist clinics to just be managed, handhold a lot more closely. Our extensivist clinic is unique to these in that these patients that are going to the extensivist clinics across the country right now, and again, there's not too many of them, are stable. They're not that acute where they need hospitalization. Our clinic is, or taking it one step further, we are taking care of patients who need hospitalization. We are delivering hospital-level care. And I'll get into that in a second. Here's some literature out on extensivist clinics. This came out of Journal of Hospital Medicine January of this year. And this is actually kind of interesting. Readmissions are no better with these post-discharge clinics. So they're saying your extensivist clinics aren't working too well. PCP stands for the primary care doc. So patients were just hospitalized. 36% of them went back to their regular doc. About half of them went to an urgent care. And then PDC is a post-discharge clinic. This is extensivist clinic. So 10% went to the extensivist clinic. And what did they find? Well, the hospitalization for the heart failure or pneumonia or whatever, LOS is length of stay, how many days. If the patient was sent back to their primary care physician, regardless of the diagnosis, they were staying in the hospital about 6 days. They went to an urgent care 5 days. If they were sent to a post-discharge clinic, that's a hospitalist like myself sending them to another hospitalist in a clinic outside the hospital. It could actually get the patient out of the hospital a little quicker. And that's probably, it makes sense. There's probably a comfort level knowing I'm sending this patient back to a doctor who can handle these acute illnesses and manage it. So lengths of stay were actually shorter with this post-discharge clinic. But look at readmissions. This is what everybody is looking and the government's looking at now. 25% for heart failure, 20% for heart attacks. They sent them back to their primary doc. About only 10% were readmitted to the hospital within 30 days, 11% one of these urgent cares. But actually it was highest if you were sending a patient to one of these extensivist clinics for a hospital follow-up appointment. Readmissions were actually higher with those patients, probably because those are you've chosen or selected sicker patients to go to these extensivist clinics. Still lower than what was before. This is also another interesting tidbit, especially for me, because we see this all the time. I get a patient out of the hospital, I do want them to see their doc. Remember that slide, how quickly they were coming back in 30 days, most of them within 10 or 12 days coming back to the hospital. So when somebody's coming out of the hospital, they're coming out weak and debilitated and they're likely to be back in the hospital in 10 days. I want them in their doc's office in 5 days to head it off, to nip it in the bud before whatever's happening gets worse. Well, you try to get a follow-up with a doc. My own partners, I'm part of Holston Medical Group. I'm sending them to a Holston Medical Group doc. I cannot get them in with that doc, and I'm their partner. 14 days it takes on average to get a follow-up appointment. Well, it's too late then. Patient's already been readmitted. You send them to an urgent care, they can get in a little quicker. Why, I don't know. In the post-discharge clinic, they got them in real quickly, and that was just because they were going to accommodate for them. So that's some of the literature out there. This was something, is this company out in California just got bought called CareMore. They were one of the original extensivist clinics, and they found, this is their own research, decreased the length of stay of the hospitalization. They did have low readmissions and below average inpatient utilization. Again, we want to keep the patients out of the cost center. A hospital to me is a cost center. That's where big dollars are being spent and lost. And they've done some work showing that their Extensivist Clinic can help. Again, ours is a little different from all of this stuff. So what is our Extensivist Clinic? What are we doing differently exactly? And what we are doing is doing hospital-level care in an office. We're, patients who would traditionally, the doctor would say, I can't take care of you, you're too sick, go to the hospital. They call us and send them to our clinic. Our clinic is comparable to a general medical floor on a hospital. We've got everything a general medical floor of a hospital has in this clinic, but it's not a hospital. What we don't have are beds. We put the patient in a reclining chair, and that may actually be a good thing, and we'll talk about that later. And we don't have any overnight stays. The clinic is open from 8 a.m. to 8 p.m. At the end of the day, they go home to their own bed. If they, we'll talk about what happens if they're too sick to go home or they can't, but this is the only difference with this Extensivist Clinic. It's not a hospital, no hospital charges. We don't have from a hospital medical floor, no beds, no overnight stays. What we do is give the exact same treatments. There's no magic here. The same thing I would do in the hospital for Mrs. Jones is what I'm going to do down in this Extensivist Clinic. I may compress the care a little bit more than you would in the hospital. They have the whole day to extend stuff out. But to be honest, once you're in the hospital, we don't do a whole lot for you at night. We're not doing on a medical floor. We're not doing interventions through the night. You get your treatments during the day, and we just wake you up at night. So we condense all that treatment into the period of time they're down in there. You're seeing the patients longer. And then you have consecutive treatment days. So if a patient requires 3 days in the hospital, you're probably going to require about 3 days in our Extensivist Clinic. They will return the following day for sleep in their own bed, get up and move around. They have to walk in, walk home, or be assisted. Come back and keep getting treated till they're stable enough to go back to their doc.
How do you end up billing? And what?
We'll get to that.
Okay.
Oh, yeah. It's in there. This is just an example, little case study. This is Leonard, and this was one of my favorite stories. This is a 90-year-old guy. He's fully active and lives alone. He runs 2 farms. He probably works 6 to 8 hours a day. He has a touch of dementia, but he's completely functional and independent. He came to his regular doctor, having trouble breathing and diagnosed with pneumonia. They sent him down to us to the Extensivist Clinic. Not only did he have pneumonia, he had hypoxia, meaning he wasn't getting enough oxygen to his brain because his lungs were full of infection. He had delirium, mild, and that's just the infection caused him to get a little confused. He was seeing things that weren't there. He had nausea and vomiting, so he couldn't take an antibiotic by mouth. He'd vomit it up. And he had this heart condition, too, that was new. That each one of these particular diagnoses, in it and of itself, would be enough to put you in a hospital, qualify you for hospitalization. There's a risk adjustment or risk severity scores, so you can compare pneumonias to pneumonias. Some pneumonias that you or I get, or walking pneumonia, we probably come to class with it. You feel crappy, you take some Z-Pak, and that wouldn't score very high on these severity scores. He scored pretty high. There's 2 different severity scores out there. There's one called CURB 65. He scored 3. Anybody 2 or higher is recommended for hospitalization. And with a 3, they recommend an inpatient hospitalization and possibly intensive care unit. The pneumonia severity risk score, it's a little more detailed. He scored 131 on that. Anybody over 90 traditionally is recommended to be admitted to the hospital, and over 130 even consider ICU. So he's a really sick guy. We got him there, gave him some IV fluid because he was dehydrated, hadn't been eating, gave him IV medicine to get rid of his nausea. Everything, no magic, everything I would have done in the hospital was being done down here. IV antibiotics, we cultured him, got basic labs, put him on oxygen, and just watched him there. He did have the first day he was there, he did have some more delirium. There's a TV there, it wasn't on, and he was seeing things, and he was brought in by his 2 daughters, who I guess in their 70s, and they were just simple farmers' daughters, but very bright and intuitive. They said, we've taken Dad, he got an infection in his bladder a couple years ago, and we took him to the hospital. And when he got to that hospital, he went from a little confused to a lot confused. And again, you take an older patient who has a touch of dementia and you put them in a surrounding that they're not familiar with, they go ballistic. You start sticking them, poking them, doing all kinds of stuff, they get really confused. So these two daughters, after the first day of treatment, he was doing better. He wasn't that wild. We kept him there about 6 or 8 hours. The end of the day at 8 o'clock, told the daughters, your dad would normally be hospitalized for this. I can put him in the hospital, or you can go home and come back and get some more antibiotics, more breathing treatments, more of everything tomorrow. And they said, we'll take him home. We'll take care of him. And they need to know at 2 in the morning if he gets into problems, you don't have a nurse down the hall, but they were willing to take that risk and took him home. He had a little confusion. They were awake for a lot of the night, kind of tending to him. But he did pretty well, came back the next day. We gave him some more IV antibiotics, more breathing treatments, watched him for a while. He started improving. The third day, he was doing well enough and was able to keep stuff down. He wasn't sick. We put him on antibiotics by mouth, and he didn't even come in, just let him rest. And then we brought him back a fourth day, and he wasn't better, but he was on the road to recovery, and we released him from the hospital at that time. So that's just a case example, and I'll give a couple more. Again, we don't force anybody to go home. We give the patient and the family the option. At the end of the day, do you want to go to the hospital? And if they do, we simply directly admit the patient. You don't hold up any of their care. You just continue the care in the hospital, bypassing the ER. I just put hospital orders in from the clinic. They go right up to the hospital floor and are watched through the night. So you haven't delayed or slowed down their care at all. The big thing is you've bypassed an ER, which can when you get hospitalized, you get an ER bill and a hospital bill. They don't get that ER bill. They don't have to stay in the ER. So it cuts a lot of the aggravation out. So getting to this, about 80% of our patients were able to manage in this clinic alone without the hospital, anywhere between 1 and 4 days, depending on the different diagnoses. 20% we do transfer to the hospital. Unlike a regular office doc who just sends them, we do the care. I write the orders up there. I'll send patients sometimes if I think they are declining, which happens in a hospital too. Have them in the clinic all day, and if they're getting worse, say, look, they may need ICU care, or they need ICU care at this point, we need to go to the hospital, we can't do this here. So sometimes the doc will send them. The other thing is that prevents us from sending patients home is the nocturnal support. Do you have a family member who's willing to watch mom or dad and keep an eye on them through the night, to drive them home, bring them back? And so that limits, but 80% of the patients that are traditionally hospitalized we can care for in this manner without a hospitalization or an ER visit. So far, that's where we're at. The patients that we see, frail elderly, that 5% we're talking about, the chronically ill, in and out of the hospital, we see a lot of these patients and keep them out of the hospital. But we also take care of young, healthy people, too. I had a 40-year-old guy who had a kidney stone. He had a fever of 102. His heart rate was 140 while he was sitting there. They were going to send him to the hospital, sent him to us. We gave him IV fluid to get his heart rate down, gave him IV antibiotics, culture, everything I would have done in the hospital. So we do take care of people outside this 5% who need hospitalization, but the majority of the patients are these frail elderly patients who are in and out of the hospital. The patients also are the patients that require this extended care, meaning doc's got half an hour in his office to see you, you need 6 or 8 hours. What's your option right now? Hospital. Well, now we've got this. Patients who don't want to go to the hospital. So that's some of the other patients. The patients do need, again, some kind of social support at home because they are unable to really care for themselves at home. And so if you don't have that, they need to be in a hospital. The staff, how do we staff this thing? The docs are hospitalists like myself. We're comfortable and used to acutely ill patients. Again, the office docs, they've been out of the hospital since their residency, 15 years. They don't know how to handle these type of issues anymore because they haven't been doing it. So it's not for only half of our hospitalists are doing it, but I think ER docs would be able to do this type of thing as well. The nurses, this is probably, the thing that makes this whole Extensivist Clinic run really are the nurses. These got to be, most of our nurses in our group are just LPNs. These are all RNs. They have to be pretty highly trained. We are demanding that they've all had some kind of ER, ICU background in a hospital for a period of time, so they're comfortable with these sick patients. They have to be able to get a good line on a patient. These patients are coming in dehydrated, and they have no blood vessels to stick very easily, so they have to be good at that. They're doing case managerial skills, setting up home health. They're doing everything. So, if you want to know how one of these things runs well, you have to have really good nurses who are skilled at high-level care. They also do pharmacy too. We don't have they're mixing up the IVs and doing so. They do it all, and so you can't skimp on your nurses or it won't work. This is what one of the rooms looks like. Again, no beds. You got this reclining chair that'll click up. This is probably the most important thing of the whole darn thing. Widescreen TV, so the patient and their family have something to do while they're there. But we have telemetry monitors, IVs. Again, just like a hospital if we need it. All the meds or drugs that a hospital would have. The other thing is we're close to our referral source. This Extensivist Clinic, you can't come to it walking in off the street. We don't accept any walk-ins. You have to be referred by a physician who's saying you need to go to the hospital. Instead, they send to us. So we're right next to our urgent care office that feeds patients. Patient comes into urgent care doc goes, whoa, you're too sick, go to the hospital. Instead, they call us and send them to us. And then a lot of our primary care providers in the group are nearby. Although we've had patients drive down from Duffield 30 minutes to come to this with the level 1 trauma center right next door, they'd rather come to the Extensivist Clinic and avoid the hospitalization. This is another quick patient we took care of in the Extensivist Clinic. It's a pancreatitis, a gentleman with pancreatitis. He's been in the hospital 2 times prior for it. Each time he was in about 3 days. I don't know what the hospitalization costs were, but you could assume $15,000 to $20,000. Pancreatitis is fairly easy to treat. Really all you do is a lot of IV fluids. Your pancreatic enzymes in pancreatitis are the digestive juices, and they get out of the bag. And just like we're able to digest a steak in your belly, these digestive juices are outside that bag and literally digesting you. So it's a very painful thing. Your body tries to send a lot of fluid there to dilute those pancreatic enzymes. So the treatment for it initially is give them a lot of fluid to help dilute those enzymes out. Don't let them eat, because anything, even if you put in their mouth, is going to stimulate more digestive juices. Give them some nausea medicine and pain control, because it's very painful. Again, no magic here. We're not doing anything different than we would do in the hospital. First day, I tanked the guy up with 3 or 4 or 5, I don't remember, liters of fluid, gave him pain medicine, nausea medicine. Second day before he came back to the clinic, and told him not to eat anything. Second day before he came back to the clinic, we had him get a study to make sure he didn't have a stone blocking this pancreatic duct causing this problem. You got to figure out what's causing the pancreatitis. He came back the second day, gave him more fluids, more pain medicine. Now, he didn't have access to pain medicine overnight, or IV pain medicine. So there are some give and takes with this, but he got to sleep in his own bed. Saw him back the third day, starting to improve. We started advancing his diet slowly with some bland foods. He was tolerating it, and we released him. So took care of acute pancreatitis, which previously, people would say you're crazy to try to do that outside the hospital. We have medicines pretty similar to the hospital. We don't have everything a hospital has, and we don't have the super expensive ones. But one thing we did learn, and I'm kind of surprised, medicines aren't that expensive. I mean, there are expensive medicines, but the basics that you need for these things aren't that expensive. We have basic radiology there, meaning I can get chest x-rays, I can get some basic studies done, phlebotomy, blood, I get blood work in. These are things you need to have in the hospital. Biggest thing is breathing. A lot of patients go to the hospital simply because they're not getting enough oxygen, and they can't go home without being able to oxygenate their brain. Well, we just give them oxygen to get them through the rough spot. We set them up, bring in a respiratory company. They give them a portable oxygen. We have oxygen in the rooms. We have this respiratory company come in, They give them a portable thing to go home with, and then they have a tank at home already set up by the time they get home. Allows them to avoid that. So patient access, again, you can't walk in. It's a doc calling, and we have this triage call. So the doc calls, it's doc to doc, so they tell, we've got this going on, and we talk it out, should they go to the hospital, or is this something we could handle here? We do some hospital follow-ups like those other extensivist clinics, but the majority of the patients that we see are these acutely ill patients. The biggest, well, let me start with patient buy-in. The neatest thing for me when we started this is, would we have to sell this idea to the patients? And the answer is absolutely no. There's no marketing to the patient. They demand it, they want it, they absolutely do not want to go to the hospital, and the families will do anything they can do to keep them out of the hospital. So we don't sell it or market it to patients. Here's where I've been marketing it the heck out of, is to our docs. It's a change in the way we do things. They're all for it, but it's a change, and they're slow to adopt to it. And so we've been marketing, call us first, and if we can't handle it, we'll take care of it and send them on to the hospital. But call us first. This is a little flyer that we put out for the docs, and the nurses of the other offices. Here's the things we can treat. Because they say, how sick are they? What can you do? And so these are a bunch of diagnoses that people would typically say, they need hospitalization. But say, no, we can do a lot of stuff. What we don't do in our clinic, though, is any ICU care, like I mentioned, any ischemic events. And I diss the hospitals pretty hard here, but if you're having a heart attack in this country, you want to be in an American hospital. You will get taken care of. There are good things that hospitals do very well. Heart attacks, we do great. That kind of a stroke, if you can get in and get the medicine treatment for a stroke in time, you want to be in a hospital. So we don't even try to do those things. We recognize hospitals do a good job of it. Trauma, if you're in a car accident, you want to be in an American hospital. We will, that is one thing American hospitals do better than anybody, those things. But what we don't do a very good job of is taking care of these frail elderly patients. So heart attacks, or concern you're going to have a heart attack, strokes, or concern you're going to have a stroke, we don't even, you need a hospital. But most everything else we can handle. This is this is my last case study. I'll be quick. It's another 81-year-old guy. He recently widowed, lived alone. He's got all kinds of problems. He's got kidney problems. He's got diabetes. He's got hypertension. He's had bypass surgery. His heart doesn't squeeze well. He normally weighs 202 pounds. He came into his doc's office with oxygen levels of 85%. Anything less than 88, you're not getting good oxygen in your brain. You're not going to think right and cause brain damage. And he weighed 216 pounds, and that wasn't fat. It was just all this excess fluid. His heart wasn't pumping off. This is a hospitalization, without a doubt. Well, we sat him down, put him on oxygen, and again, no magic, just the same treatment I would do in the hospital, IV diuretics, wring that fluid out. We did here, kept him there all day, gave him a urinal, and he just peed and peed and peed. I think the first day he came late. He came about 3 in the afternoon. We kept him till about 7 or 8, and we got 3 pounds off, sent him home with oxygen, brought him back early the next day, and kept him there all day long, and we got 9 pounds off the second day of fluid, just diuresing that. It's all pee. It's all just peeing it out. By the third day, at the end of the day, he was down to 201 pounds. So we treated him there 3 days, and it would have been at least a 3-day hospitalization, and he got to sleep in his own bed. And he had some family stay with him. Again, we don't leave an 81-year-old alone. So cost of care. What do we? You asked the question. What are we charging for this? Well, right now, all we can charge are office codes. And again, those office codes aren't going to pay for the care. If you're just doing a fee-for-service, the only thing available, the only thing I can charge Medicare is an office code, which isn't really more than the highest level, more than $240. We can charge some infusion codes each time we give an infusion, but the group is losing money on this adventure just based on the fees we're charging, because we can't charge the hospital charges, and there's no other charges out there. So how are we making it happen? How, because it's a losing proposition. I've got, think of a doc's office. He's got 5 rooms to see patients, and he can turn over about 8 or 10 patients in a room in a day. Well, I've got one patient sitting there all day long. I can't keep putting other patients in. So, number one, I can't see that many patients because I'm with them for several hours each, and they're stuck there. So you're not going to make any money on the traditional fee-for-service model. Where we're hoping to recoup this, where we think healthcare is going, is pay for performance. And so we've contracted with a lot of the private insurers who are very interested in this because they're paying that hospitalization. And so we have these risk-based contracts with them, and if we take care of their patients cheaper than everybody else is taking care of them, they will give us some money back. Medicare, the government does this as well in something called shared savings. If we take care of our Medicare population cheaper than everybody else is taking care of their Medicare population, and we're doing it cheaper because we're cutting out $20,000 hospitalizations. After 18 months, this money isn't up front, after 18 months, some of that money we have saved Medicare, the government will come back to us for the performance we did, giving better care, well, cheaper cost. I do feel it is better care. So from a hospital's perspective, I don't know if there's anybody affiliated with hospitals here, but I threw this up, and again, these are just my thoughts, but what would a hospital say about what we're doing? Because again, I don't work for a hospital. Well, number one, I think the first thought, everybody, we're taking patients out of their beds. We're taking their money. So our hospital's going to be upset about this. If that's all you think about, yeah, I'm treating their patients, they're $20,000 down there for less than $1,000 for 3 days. But what is this Extensivist Clinic doing for the hospital? Well, it's decreasing the length of stay by having that Extensivist Clinic on the front end. And what does that mean? If you remember the 20% I do have to send up to the hospital from the Extensivist Clinic, they spent a day in my clinic, so their length of stay is shorter by a day because they've gotten their first day's treatment with me already. So you're shortening that length of stay. And hospitals get a lump sum. You come in for heart failure, the hospital will get X amount of dollars whether you stay 10 days or 3 days. So I'm cutting that length of stay down. They get this lump sum whether the patient's there 2 or 10 days. I'm cutting it down so they don't have to keep them as long. The back end, if you're sending them to one of these Extensivist Clinic and follow-up like you saw from that one article, getting them out a little quicker. We're decreasing readmissions to the hospitals. We're not only decreasing their patient readmissions, we're really decreasing all admissions, but you're cutting down on readmissions as well by decreasing. And hospitals, again, are starting to look at these readmissions. Again, I don't think the government penalties are severe enough yet, but they will be over the next several years, that hospitals are concerned about that readmission in 30 days. Is there a patient coming back to the hospital within 30 days? We're cutting that down. This is something else, minimizing low reimbursement admissions. And this, one of the chief financial officers at one of the hospitals once told our hospital team, we don't want your patients. And he's right if you're looking at it from a financial sense. The patients that I take care of, these frail elderly patients, are not big money makers. Even though the hospitalization is expensive, there's a lot of cost to it. Hospitals want the big dollar procedures, the cardiac patients where you put a stent in. They want the hematology oncology patients where you give them chemotherapy, the orthopedic patients where you're putting a hip joint in. Those are the money makers for the hospital. And so there was a chief financial officer who actually was bold enough to say, we're not even interested in your patients because those aren't our big money makers and they just clog up our system. So those are the patients we're taking care of, these patients that aren't their big money makers. So it is actually doing them a service and allowing them to get their big money making patients. And we also decrease ER congestion, and that's a big thing with hospital performance, how well or how congested is the ER. I don't know if you guys have ever been in one lately, but they're stacked up in the halls. If we're keeping them out, even the patients we admit to the hospital don't even go through the ER. We've done it. So that there is some benefit to a hospital, even though one might say we're stealing their patients. So in conclusion, our care delivery model offers significant cost savings to a system. Again, those hospitalization, the three examples I gave you of the patients that we treated, probable total costs to the insurance are paid no more than $1,500 versus $15,000 or $20,000. So huge cost savings. But for me as a clinician, as a doc, even more exciting is that it may provide better care to our patients. Patient satisfaction is huge here. In the hospital, I see a patient once a day for maybe 15, 30 minutes. In this clinic, I'm seeing them 6 or 8 times throughout the course of that day, and bedside with them upwards of several hours. So they're getting all this care. The nurses are right there. Patients are very pleased with the care. We may be decreasing, and these are things I'd like to see researched down, and just some ideas from. These are clinical things. I mean, obviously there's a lot of financial research that could be done, but are we decreasing the delirium in the elderly? Are the patients going through this Extensivist Clinic less likely to get confused because they're staying in an environment at night that's their own, that's comfortable to them? Are they sleeping better? Are they less deconditioned because they're not lying in a bed for 3 days straight? We worry about clots developing in patients in the hospital, and we put them on blood thinners to prevent the clots. We don't give them blood thinners in this thing because they're moving around. So there's a lot in the future to this. Going forward is Dr. Eric Topol. He was noted as one of the most influential physician executives in healthcare. He's the CEO of Medscape, and I think this was in Forbes or something, the hospital of 10 years. He was actually predicting hospitals will only be intensive care units in 10 years, meaning all this lower level stuff will be handled somewhere else. Where he doesn't know about our Extensivist Clinic, but where would it be? I think in an Extensivist Clinic. And then another thought, I don't know if you, I'm sure you probably have heard down here, but the Lee Regional Hospital was closed down. The community up there wants a hospital, wants an ER. It costs a lot. I don't think the community itself is going to be able to raise the money, but could we, these are things we're looking into. Could we put an urgent care in an Extensivist Clinic like we have down here up there to mimic the urgent care doing the same thing an ER would do to a certain degree? Again, you're limited. Gunshots and heart attacks, you wouldn't even stop at this. You'd go on to the big hospital. But all the other stuff that falls a little lower than that, could an urgent care do what an ER is doing? Could this Extensivist Clinic do what one of these community-based hospitals is doing when you don't have the resources and finances to do that? So could these things be placed in underserved and economically deprived regions? Maybe, and that's kind of what we're looking at. So that's it. Do you have any questions?
That was really interesting. I mean, it sort of strikes me as this is where outpatient surgery was a couple of decades ago. Suddenly you're moving, you're saying, there's much more we can do outside the hospital. It seems like you've got you talked about evaluation. You've got the cost, the economic impact evaluation, which you've touched on, but I think there's a huge amount you could do. Even that chart you showed with the post-discharge readmission, the readmission rate was higher. It was 38% higher, but the length of stay was 37% lower. So it's at least a wash, and maybe better depending on how long they're readmitted. But the one that really intrigues me is you think about the number of elderly who go into the hospital from an independent setting, stay in the hospital, and then end up having to go into assisted living. It seems like you would be preventing that, and that might be an easy way to study. It would just be to look at a group of elderly with common diagnoses and what % end up going back to independent living and what don't.
Yeah. Oh, yeah. I think there's a lot of stuff that can be done on this. And I'm not a researcher, but that's why I'm here to talk to you guys, see if anybody's interested. I mean, there's all kinds of things you could look at with this. I like your outpatient surgery, and that's a great analogy in that when people taking a gallbladder out 25 years ago, or maybe 30, it was a big incision from here to here, and you were in the hospital for 2 weeks to take your gallbladder out. Today, we do it in an outpatient, most of them, outpatient surgery center. You go in the morning, you get little holes here, here, and here. You go home that afternoon. And this is kind of like that.
I had the same thought about the patient with the ejection fraction of 40% and I think it was CHF. Was that that would have been a nursing home patient? I mean, that would have been a subacute rehab patient. That was our typical.
And whether it's due to the
Not getting
PostHospital
debilitated,
syndrome or whatever, I mean, it's, 'cause that's all.
I'm going to take that home with me. Thank you.
That's always been the thing that's bugged me, is how many elderly go into the hospital from an independent setting and then don't go back home. End up in his world.
Yeah.
Well, I mean, part of it, quite frankly, that post-hospital syndrome, I believe that. I saw. I mean, we were the post-acute care, and a lot of our challenges were the result of that very thing.
Just to explain, Chris, Colin was a nursing home administrator for several years before joining our faculty, and continues to have his license. So just to put, I guess, the discussion in context. Yeah, please.
Yeah. No science to it, but it rings true. I mean, I see it, and I don't do a good job on my patients in the hospital. We just don't with the system we have right now. And we may be making them weaker and throwing them into this ongoing.
Do you cap patients in the clinic?
Yeah, we only have 5 rooms right now, and if they're filled up, and they're there all day, we have to turn them away, and we're already starting to turn them away. We're working on getting more space to do this because there's so much of an interest for it. Yes.
I also think that's a very innovative topic. And you might have mentioned it in your presentation. Do you think this is going to become more popular in terms of having more of these clinics?
Yeah, I think, my personal opinion, it's going to be the future. They're going to start cropping up everywhere because, again, my opinion, it's better care because you're more focused, and it's literally 1/10 to 1/20th the cost. So it will be adopted, and you will start seeing these things. We're talking about, and here's something else you guys might help us with, the name, Extensivist Clinic. Nobody knows what the heck that means, and we're trying to come up with a better name to separate us from the other Extensivist clinics and kind of describe what we're doing, and, I don't even know what extend, so if you got a better name,
I think the thing that's missing from this that you'll be challenged to think about is the self-referral. Right now, a lot of folks go to the ER as a self-referral, either because they don't have a primary care doc, they don't have insurance or whatever. Can you see a model of this where people could self-refer?
Well, what we'd like to get to at a point is if they do, the 5% of the 6, we kind of allow them, if they're getting into trouble and we know them, there's kind of a self-referral. They know when they're about to go. So we do actually bend that a little bit. The big issue is they end up in the ER. Can you send them, instead of admitting them to the hospital, down to this clinic? And I'm in the hospital, in the ER, admitting them. Technically, I could say, Mrs. Jones, rather than go in the hospital, go down there. But this is not standard of care as of yet. I do think it will be a standard of care in the future. So from a legality standpoint, it's tough to take a patient who needs hospitalization out of a hospital and send them to one of these clinics. So we haven't done that yet. It may be, but I do foresee that in the future, where even this patient shows up in the ER and we have the ability, when it's more of a standard of care and we're less likely of, to be getting sued for not practicing standard of care, sending them down to this clinic rather than into the hospital.
But it's a slippery slope, of course, because if you start de-referring patients who don't have insurance disproportionate to those who do, then you get all sorts of issues.
Yeah.
So I think the big barrier to it becoming a standard of care is your billing source. I mean, is there any movement from the American Medical Association or some organization to pressure CMS to have codes for an acute care clinic, or because literally, I think your big barrier is not being able to. Sure.
Yeah. Well, this is so new, I don't think CMS even knows about it, but that would help if there were these codes, and I do see that as helpful in the future. But again, if our group's feeling is we're switching or moving away from fee-for-service and going towards pay for performance, and we expect, we're still a losing proposition right now, but we expect to recoup money by taking care of these patients a lot cheaper.
But I'll just add to that, Chris, that pay for performance is actually modified fee-for-service. So that's not taking fee-for-service away.
Yeah,
it's
yeah.
modifying fee-for-service to account for
this.
quality outcomes.
Yeah.
So I would actually think that some advocacy to perhaps develop policy and billing codes is a good thing to sustain, to be able to sustain the clinic.
Yeah, we've talked about advocating for these longer period where you're treating a patient for 8-10 hours and a special fee-for-service code for that. Again, we've only been doing this for a year. Nobody else that I'm aware of in the country is doing something like this, and we're small. But if this is going to go forward, I would expect there's probably needs to be some kind of
research.
Yeah, I mean, now that you've documented the feasibility of the model,
Yeah.
I guess you have more basis to publish the work that you're doing and perhaps begin to.
Well, that's how you start advocacy.
To advocate. So if you haven't heard clearly yet, Dr. Neglia is here, to recruit a student.
Thank you. Yes.
For
Because I don't know research, epidemiology, stats.
for internships or for class projects to engage in some of those evaluations. So whether you're interested in studies, of process improvement, QI, cost analysis, writing a manuscript about this model for publication in a maybe not initially in a peer-reviewed journal, but hospital medicine or other trade publication, advocacy. So there are really lots of opportunities here for students with different interests and trainings. And so he's hoping that you will take him up on his offer. And I can speak for Mr. Chesley. He'd be happy to facilitate, that process for you if you are interested.
Thank you very much.
Okay, and if they'd like to talk, if anyone would like to talk with you for a few minutes,
Sure.
is this
And
the best
that's
way to
my
reach you?
Yeah, that's my email. Best way to reach me. But I'll be happy to talk for anybody
So
if you have questions.
You can hang around after the presentation. Wonderful. So we want to conclude with just a certificate
thank you.
of appreciation and a
Bottle of
small
scotch.
token to say not in front of my dean, but in another setting.
Thank you very much.
Folks, again, this concludes Breakfast with the Expert for this spring. Good luck on your final exams and field presentations starting tomorrow. And we will restart Breakfast with the Expert, of course, in the fall semester. I hope you can join us.